Good evening, everyone. My name is Jonathan Barr, and I'm back for episode 3. I hope you guys enjoyed the first 2 episodes. I was hoping to do this training in person with you guys, but due to some scheduling issues, it seemed like not enough people could make it. So I've instead made a recording on patient assessment, and hopefully we'll be able to do an in-person version of this in the near future. You'll notice my contact/title changed a little bit. I finished up fellowship at Cooper, and now I'm working full-time at the University of Pennsylvania. And so if you need to find me, that's where I'm at now. Let's dive right into it. But first, take a minute to read this disclaimer here. All right. So patient assessment in the field is one of the most fundamental things, and it involves really 6 items, of which you're going to do the first 5 in the field, but I want you to understand what the 6th one is. So that's scene size up, primary survey, secondary survey, disposition, transition of care, and then later the patient will eventually get a tertiary survey, and I'll explain what that is and why it's important. So how are we going to do our scene size up? So the scene size up involves these 6 elements. You should be able to rattle these off in your head without even thinking about it. I encourage you to pause on this slide and repeat these out loud to yourself 4 or 5 times to really make sure these are burned into your mind. Hopefully in EMT school you did this in front of it before every scenario. But again, you're checking the scene for safety. BSI, PPE, how many patients are there? What's the mechanism of injury or nature of the illness? Consider C-spine. And consider additional resources. And this should be automatic to you. As soon as you're walking into the scene, you should already start thinking about this. And in fact, Brian Lubroth, our very own fellow in ambulance corps, I remember, told me once, before you even walk into the scene, you should be thinking about how you're getting out of it. And that wisdom holds really true, especially during my time riding around as an EMS physician in Camden and in the other EMS capacities I've been involved with over the years. It's very much true, and that's part of the scene size up, is looking at the scene, looking how you're going to get out of it later, because a lot of that is going to be what matters for the patient when you need to get them to a higher level of care. So after you've done the scene size up, remember, what was the scene size up again? Check the scene for safety, number of patients, mechanism of injury, nature of illness, consider C-spine, consider additional resources. Again, remember that, say it to yourself multiple times, should be automatic for you. Then you're going to do the primary survey, and this should automatically come into your brain as well. You should be able to do this without even thinking, and you should be able to do it fast, okay? The important thing to remember in the primary survey, sometimes, by the way, you might read in some EMS textbooks the initial assessment. For the purposes we're talking about here, initial assessment and primary survey are going to be considered one and the same, but just in case you've seen that term before. The primary survey is to identify and correct immediate threats to life. I'm going to say that again, to identify and correct immediate threats to life. Now, what are those? Classically, it's taught as the ABCs. I've modified it a little bit because I want you to think about a few more things in a particular order. So first, I call this the XABCs, where X stands for exsanguinating hemorrhage. You may have heard that terminology if any of you have taken a TCCC course. That stands for Tactical Combat Casualty Care. Some of you may have also heard of MARCH, which is specific for trauma, and that M in MARCH is for massive hemorrhage. So you'll notice the importance placed on treating exsanguinating hemorrhage early and putting it early in ABCs, and that's because in trauma patients, that's what kills them. They die of hemorrhage more so than airway and breathing, and so in the setting of exsanguinating hemorrhage, you need to address that first and foremost. What does that mean? That means someone with arterial bleeding, you put a tourniquet on. This is where, as BLS providers, you can really shine and perform an intervention that saves a life, right? This is a BLS skill to control exsanguinating hemorrhage, and this is why I'm emphasizing it so much, because you can fix this. You can put pressure. You can do elevation. You can get tourniquets on, and you can and should do these things because that's what's going to save lives in the setting of trauma, okay? So X, exsanguinating hemorrhage. A, airway. B, breathing. C, circulation. I think that's drilled into everyone. D, disability, dextrose, and diesel. Okay, what does disability mean? You want to know if the patient is going to be disabled from this. So one of the things you can do is calculate a GCS score. Don't know how to do GCS? Go on MD Calc right now. Type in MD Calc into your web browser and Google and type GCS, and you'll see how to do it. But you should know how to do it, and if you don't remember how to do it on your phone. okay? Because you should have a GCS score on your patients, okay? It's important also to know the GCS because that's the criteria for them to refuse also. If they need to have a GCS of 15. So if you're not familiar with it, look it up. We can talk about it later. I don't want to spend too much time on it here, but know that that's what, when disability, we're talking about that, get their initial GCS and anything else going to be disabled. Are they paralyzed? Are they weak somewhere? They have weakness in one of their arms and legs. So it's a cursory neuro exam, right? Okay. Dextrose, blood sugar. I put it here because I expect that BLS in the near future will get blood glucometry as a skill. Okay. And even if you can't do it yourself right now in the state of New Jersey, the patient can often do it, or the patient's family member can do it, or ALS can do it. So you should have it in your mind getting the glucose early as part of the primary survey. So I'm putting it here because I want you to remember it. So dextrose stands for get a blood glucose. And then diesel stands for maybe you just need to get to the hospital. And in trauma, that's particularly true. Time to definitive care is the single most important thing in trauma. And as BLS providers, you can really shine here. This is a BLS intervention. And it's important because this is where you guys can affect this change. And then E stands for exposure. That means multiple things. One, exposing the patient. So in the setting of trauma, doing getting clothing off. It also means protecting from the elements, so hot and cold. And so patients need to be kept warm. And we often forget about that. We undress them to examine them. We don't cover them up. And so it's important to remember that. Now, I mentioned a lot of trauma examples as I was talking through this, but this also applies to medical patients, right? You can run through this on a patient chest and say, well, no exsanguinating hemorrhage, airway's intact, breathing is labored, circulation, he's clammy, he's got poor distal pulses. I'm worried that he could be in cardiogenic shock from his heart failure. Remember we talked about shock last time. And you can go through it that way. So I gave a lot of examples in trauma, but this also applies to medical patients, and you can apply it that. Obviously, in medical patients, some of them are going to be fairly quick, like, right, they're not exsanguinating, great. But they might be. For example, GI bleed is a medical illness, but it involves exsanguination, so important, right? So these are things, you should be doing this on every single patient, okay? Primary survey on every single patient. And if there's a problem with any one of these, you need to correct it before moving on. So the next thing to do after the primary survey is the secondary survey. Now, secondary survey, you're basically doing a head-to-toe physical exam looking for decap BTLS. What is that? Deformities, discoloration, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. That's what decap BTLS is. So you're looking for that all throughout your secondary survey, okay? Now, how long should it take you to do your scene size up primary and secondary survey? Less than 10 minutes. 10 minutes or less. So you're going to do this fast. And you should have the primary survey done in even quicker, in the first few minutes, okay? But really 10 minutes or less, and you should have this stuff done, and you should be thinking about how you're getting out of there, okay? And that's where disposition comes in. Do you stay and play and work on this patient where you are, or do you load and go? Now, you should know this answer by the 10 minutes or less. Okay, I want you to really practice your assessments to get so good at them that you can get a primary and secondary survey done within 10 minutes and know pretty much, are you going to stay or you're going to go? Okay. So we talked about scene size up. We talked about primary survey. We talked about secondary survey. We talked about disposition, stay and play or load and go. Okay. And to know when to stay and play or when to load and go is going to take some experience. And I think this will be better taught when we go through some scenarios in person, and I'm hopeful we'll be able to reschedule that. So we'll come back to that. But once you go, and once you get to the hospital, I want to call attention to the transition of care. This is something that's often forgotten or not emphasized or not done well, and it is the single most important thing you're doing because this is where most errors occur, where a lot of communication issues occur, and where a lot of problems in patient care occur. Now, I can't tell you how many times I've been an ER doctor on the receiving end, and I get a patient that was brought in by EMS, and the triage note that was written by the triage nurse that EMS talked to, all it says is fell at home. And the patient has altered mental status. They can tell me only their name. They can't tell me anything that happened. There's no family phone number in the chart. They don't have an ID. And I'm there trying to figure out what's going on, like what happened. And they're not alert enough to tell me. And I didn't get any information from EMS because they already gave a report to the nurse and left. And so this happens all the time. And I can tell you it's not good for the patient, because this patient gets more unnecessary tests, and they get unnecessary things when we don't know what happened to them. And what I'm saying is the information you get as EMS is important. Okay. And there are a lot of sometimes issues I've noticed in the transition of care. Sometimes EMS feels like their information is not being heard or not important. And sometimes the EMS might feel like they've been blown off. And if that's happened to you, I'm not surprised, but I'm also sorry that you've been treated that way. But this information is critically important. And sometimes the only information we'll get, okay? And how you communicated it is really important as well. I'm going to tell you something about medicine. In medical school, when you're getting evaluated, you see a patient, you then present the patient to a more senior doc. You give a patient presentation. That's basically you summarizing the case and what you think about the patient. They judge how competent you are and how good you are often on how good your presentation is. Like, do you sound like you know what you're talking about? Do you sound like you did a thorough exam? Do you sound like you did a good job? Doctors, when they're listening to a report, a nurse will listen to a report, they're going to make a determination about whether or not they can trust the care you provided based on how you communicate that. And so it's really important that when you make your report, that it's professional, that it's organized, that it's accurate, because that's going to instill the trust between you and the ED team, okay? Because and this is helpful if you know the nurse, you know the providers, they have a baseline level of trust, it's a lot better. But oftentimes you don't. I can tell you, I often don't know the EMS providers coming in, and I don't know how good they are or not. Some are very good, some are not. And the quality of the report really helps a lot. And so I'm emphasizing you really need to give a good quality handoff. Now, there are a lot of ways to do it. One way that's been kind of touted is this format called MIST, or sometimes people call it DMIST because they say DE, which stands for demographics. Now, you'll note in this thing here, it actually includes the demographics here, name, age, sex. So, I mean, they're essentially the same, but this is one format you can use. So M standing for mechanism or complaints. You're going to say, like, hey, if it was a motor vehicle accident, you're going to give all the stuff about the mechanism. If it was a fall, you're going to talk about the distances, things like that. If it's medical, you're going to talk about the onset, the duration. How long was the chest pain going on? When did it start? What was going on at the time? Were they lifting heavy objects? What was happening? You're then going to talk about your exam. What injuries or illnesses did you identify? Okay. You're going to talk about signs and symptoms. Okay. And you're going to talk about the treatments given. So what does that sound like? Okay. I'm just going to make up a case right now. It's not a real patient. As this is online, I don't want to give any real patient information. I'm going to make one up off the top of my head. Okay. Just say, hi, doc. I'm here. I'm bringing in a 27-year-old male. No significant past medical history. Who was brought in after a motor vehicle accident. It was at a rate of speed, we think approximately 35 miles an hour based on the road sign. He was restrained. There was intrusion into the vehicle. The patient did not strike his head on the windshield. There was no spidering. On exam, we noted that he had deformity to his right leg, and we applied a splint there. His vital signs were heart rate of 120, blood pressure of 100/80, oxygen sat 98%, respirations of 16. We didn't check an end tidal or blood glucose on this gentleman as we didn't have ALS, and his GCS was 15. He's mostly complaining of pain to that area. So far, we've just applied a splint, as you can see here, and he hasn't received any pain medication. Do you have any questions? That would be an example of how you might use this format to communicate. Now, there are other standardized formats that you can use. If you want to tell me about them or have a discussion about them, I'm happy to do so. Feel free to throw them in the comments or reach out to me. But the important thing is that you have a process. And this isn't just me, it isn't just my opinion. So there was actually a joint statement between the National Association of EMS Physicians. So that's a national organization that I'm part of as an EMS physician. And it was a joint statement between that and the American College of Emergency Physicians, which I'm also part of, the Emergency Nurses Association, the National Association of Emergency Medical Technicians, and the National Association of State EMS Officials. They had a joint statement that basically said that you need clearly defined processes for face-to-face communication of key information from EMS providers to healthcare providers in the emergency department as critical to improving patient care. Okay, so a lot of smart people, a lot of organizations have identified this as an area that needs work and needs improvement. And so you need to have a clear process. Okay, this is one that you can use. And it's important, I think, to work with the local hospital so that they're comfortable getting the information in this as well. Because it's been shown that if EMS adopts this, but the hospital doesn't understand this format, then it also is only sort of good. It's not as good. Okay. So key things here, the transition of care is important. Have a format that you use. This is one format that you can use. Stick to it and be consistent every time. And the way you deliver it matters. Okay. Now, I mentioned in the beginning this thing called a tertiary survey. Tertiary survey is something that we'll do in the hospital often the day after the chaos of an initial resuscitation or initial injury. And that's to find any injuries or any problems that were not identified, maybe because it was masked by adrenaline and things in the initial assessment. I'm telling you this because things get masked by adrenaline, by drugs people did in the street, by other things that you may not find it in the initial thing. So I'm telling you that we do this because it's expected that you're going to miss some stuff. But also I'm saying is because you often miss stuff, double check your primary and secondary surveys. Okay. And we really it's really important to do them accurately. And we're going to often do a tertiary at some later point because often stuff does get missed. And it's not your fault if something gets missed, but it's something to think about and do the best you can to miss as little as possible. Okay. I can tell you, I've had patients who, when I initially was assessing them, didn't see a bullet hole in them because it was so small. Okay. And that it can be really tricky, especially in that particular scene. It was very dark. Couldn't really see. There wasn't good lighting. Couldn't really tell. And then when the lights came on and I was doing my secondary and repeat service, I'm like, oh, wow, there's a hole here I didn't see before. Okay. The size of a pinhole, wasn't very big because the tissue had collapsed on itself and the patient wasn't bleeding a lot from it because her cardiac output was low. So it's easy to miss these things. And I can tell you I've been humbled by stuff that I found on later examinations or repeat examinations I didn't notice originally in the initial heat of the moment, the heat of battle. Okay. So keep that in mind. Slow is smooth, smooth is fast. Do a good primary and secondary survey and know that this exists because not everything gets found on those. And so the better you can do, the better. Otherwise, these patients need tertiary as well. And if you're with a patient long enough, like during a mass casualty or something, you might need to do a tertiary survey. So something to think about. Now, the way I presented it to you of scene size up to primary survey to secondary survey, tertiary survey, I've presented it in a linear, you do one, then the other, then the other. The process really in real life isn't that linear, okay? Because you might have to go back to a previous step if there's a problem. So you might do a scene size up, get your primary survey. Then let's say, oh, the scene is no longer safe. I have to go back to scene size up again, and I have to maybe do something different. Now, that could happen at any point. That could happen at the point of the secondary survey. That can happen at the point of you're saying, oh, when you go to the hospital, scene's not safe. We got a size of scene, or maybe we just need to get out of there. Maybe I can't stay and play anymore. Okay. Now, this could also happen if the patient deteriorates at any point. You got to go back to the primary survey and identify those threats to life, right? So it's not a linear process. It often circles back and gets repeated over and over again. In that patient I had where I didn't see the bullet hole, it was in the secondary survey that I didn't find it. And then I realized, oh, we have a life-threatening injury. I had to go back and do a primary survey again because we didn't see it originally because it was too dark. Okay. So these are things that are important. Okay. Now you might find when you're trying to get out of there, you can't get out the way we thought. So we have to size up the scene again. Okay. So this is what I'm getting at, is that it's not linear. Okay, I presented it linear, step by step. You can think of it that way in your mind, but you should also be thinking, hey, if there's a problem with the secondary survey, I got to go back to primary survey. If there's a problem with disposition, I might have to go back to scene size up even. I might have to go back to primary. You always have to reset to the point where you need to go back to address the issue you're seeing in front of you. And that's kind of the norm. Okay, this often happens. So let's take a look at some scenes and talk about some scene size up, scene safety issues, right? Look at this motor vehicle accident. And by the way, these are all photos I took from news stories that are publicly available. So, and I'll include the links at the end. So look at this accident, right? What are some of the hazards here? I'm going to pause. I want you to think of them to yourself for a minute. Think of them out loud. Good. So now that hopefully you've come up with some of the ones that I think of when I see this are: one, glass, right? How tempting it is, you walk into a motor vehicle accident, you got your rubber gloves on, you put your hand on the window and there's a bunch of broken glass there and the glass is all now in your glove. So that's an easy way to get cut, easy way to get exposure to bloodborne pathogens, right? So look at the glass. Are there fractured pieces of metal? Could the airbag still go off? Is there leakage of fluid like gasoline or antifreeze or other fluids that either can be slippery or fire hazards? Now look at the scene that's near a road. Are there other vehicles that could hit into this vehicle? Look at the tree. Did the tree that it hit, like, is that tree stable? Could that tree fall now, right? What are the law enforcement officers doing? Was the patient inside high or were they hostile in some way, right? How did this person crash their vehicle? Something to think about. Okay. So these are some of the scene size up things to do. Now, the other thing to think about is this vehicle still on or still running, right? That's another thing to think about. Is the parking brake still work? Do we need chocks to secure the vehicle by chalking all the wheels? Things to consider. Do we need the fire department to cut the door or secure the scene? Things to consider. Look at this one. What are some of the hazards here? So some of the things I see, one, the fire obviously is a burn hazard, things like that. The smoke inhalation is a hazard. But also look at the crowd forming, right? Sometimes the bystanders can start to interfere. They can clog up traffic. They can prevent egress, right? They might get agitated. They might be worried that their family members in there and they might act or do something that could maybe put themselves at risk, like trying to run in there. They might urge you or push you to try to go in there when, right, that's a burning building, right? That scene is not secure. That scene has to be secure. So these are some of the things to think about in this here. Now, also note there are other motor vehicles and other buildings around, so they could become fully involved. This, if you're wondering where these streets are, by the way, these are streets in Philadelphia. This one's in Colorado, though. What are the scene hazards here? Right, so this is a very different case, but one of them that you'll encounter in Fairlawn is snow, right? Is it creating a slippery hazard, ice hazard? Is it too cold? Is it causing an environmental hazard? Are we dressed for the weather? Hills, right? Is the patient on a hill somewhere? Right, there are some hills. You might have, maybe a sledder at TJ or Mills, right? Got hurt on the hill and it's slippery and you're trying to carry him down the ice, right? So something to think about. This is not that crazy, maybe not at this height. We don't have big mountains, but you might have to get someone off a snowy hill in the wintertime, okay? So think about some of the hazards involved here, right? Ice, snow, slipperiness. In general, at the ambulance corps, unless things have changed since I've been there, there's no technical rescue involving ropes, but the ropes do create some additional hazards for tripping. They can get snagged on things, but some things to consider there. What about here? So this is a high angle rescue. You won't be having, I don't think, too many of these scenarios in Fairlawn, but you could have a confined space rescue in some of the industrial places, and you may be supporting teams that are going in there. So something to think about. But in here, you have to worry about the elements, the outside weather, the equipment, the ropes, other people, things like that. So take a look at the scenes carefully. Now, this was one where there was an explosion on a ship and pararescuemen had to work in a confined space there, right? What are some of the hazards and things you might see here? So fire, limited space to do equipment, easily to run out of equipment, not a lot of space to maneuver in and out, some of the issues with that. So it's a good idea to start to kind of look at some of these scenes. And one kind of extra you could do is like look at some news articles, some emergencies, and think to yourself, hey, what are the scene hazards here? What are the things I should be aware of? You can kind of play this game with yourself and think of as many as you can come up with. And if you guys have thought of even more than I have, feel free to reach out to me and let me know. Okay, this is another water rescue type thing. And there are some bodies of water in Fairlawn, usually not swift water, but right, there's currents. There's ropes involved. There's a diver diving out there, right? That he's potentially at risk. He may need help. So things to consider. So I'm going to summarize this up here. So when you're doing your patient assessment in the field, you're going to start with the scene size up. What's the scene size up? Again, check the scene for safety, number of patients, mechanism of injury, nature of illness, consider additional resources, consider C-spine, okay? Primary survey, XABC, DEs, right? Exsanguinating hemorrhage, airway, breathing, circulation, disability, dextrose, diesel, E exposure. And if there's a problem with any of those, you need to address them before moving on. Once those have been addressed, because they're immediate life threats, you can then move on to the secondary survey, where you're going to do a head-to-toe exam. You're going to look for your DCAP BTLS. And if something, the patient deteriorates, that gets worse, what are you going to do? Back to primary survey. And you're going to start over again, right? Scene becomes unsafe. What are you going to do? Back to scene size up. You're going to change something differently, okay? After your secondary survey, you got to make a call within 10 minutes. 10 minutes or less should be your goal. Make a call. Stay in play, load and go. Okay, and you got to get the patient dispoed, okay? As I was emphasizing there, the assessment isn't always linear, and the transition of care at the hospital matters, okay? You want to sound professional, you want to sound fluent, you want to be organized, and you want to use a good format. And you can use the MIST format that I suggested or a different one, but you want to have a consistent format, and you want the hospital to be on board with it so they know the format. Now, I didn't mention this earlier, but one other thing is a written copy of the PCR is very helpful too, because people forget things sometimes in the handoff. They don't always get written down. So having a written version is also very helpful. So with all the talk about scene safety and scene size ups today, guys, stay safe out there. I have another part to this that I want to do in person and do scenarios and go over the assessments and how you're going to do these. And I think that's best done in the in-person format, so we'll schedule that in the future. But hopefully this will save us some time when we do that, and we can do more scenarios now that you kind of got the basics here. All right, see you on the next one. And if you want those stories about those rescues that I posted about, you can take a look at them here. Okay.